Thank you, everyone, for joining the WEO First Journal Club for 2023. It is my great pleasure and honor to welcome you all today. I am Krish Ragunath, one of the gastroenterologists and Professor of Medicine at Royal Perth Hospital in Perth, Western Australia, and a previous chair of the research committee of the WEO. Importantly, it is my great honor and pleasure to welcome Professor Hisao Tajiri from Japan, who is our president of the World Endoscopy Organization. The World Endoscopy Organization, as you all know, is the voice of global endoscopy, and it is a real pleasure for us to kickstart the 2023 educational event with a webinar. My co-chair, Professor James Law from Hong Kong, will introduce the presenter. And I would like to now hand over to Professor Tajiri to say a few welcome words as the president of the WEO. Thank you very much, Dr. Krish.
Thank you, Chris. Good evening. My name is Hisao Tajiri. It is my great pleasure to address you on behalf of the WEO. The WEO has been promoting endoscope education from a global perspective, formulating white papers, guidelines for safe and high-quality endoscopy procedures, and conducting international academic research activities utilizing its global network. Now, the WEO Research Committee, the chair is Professor Anthony Teoh, who formed a subgroup called Journal Club, led by Professor Chris Ragunath, and Journal Club decided to do a series of webinars in 2023, and this is the first webinar of this year. Today's webinar is conducted in collaboration with AERF. I look forward to lively discussion. So please get started, please.
Thank you, Professor Tajiri. Today we have the presenter, Dr. Caroline. She's a surgeon, a surgical specialist to the surgical endocrine service at the Prince of Wales Hospital, Chinese University of Hong Kong. Following Carol's presentation, we have two discussants. The first is the current chairperson to the research committee, Professor Anthony Teoh, also from Prince of Wales Hospital. And also we have Ravi from Singapore General Hospital. He's a clinical assistant professor from Singapore General Hospital with an interest in obesity surgeries amongst many of his other interests. So let's get started. We'll ask Carol to give the presentation on the MERIT trial. Thank you, Carol.
Hello, everyone. Can you hear me? So let me share my slide first. Okay, so hi, everyone. I'm Carol from Prince of Wales Hospital. I'm very happy today to be here at the first Journal Club webinar of the WEO. The paper for discussion today is the Endoscopic Sleeve Gastroplasty for treatment of class 1 to 2 obesity, the MERIT trial, which is a prospective multi-center randomized trial. In the following minutes, I will introduce to you this paper and also bring you through the study design, methods, results, and also critically appraise at each step. First of all, it is a multi-center randomized control trial published in Lancet last year, involving a total of 209 patients recruited from 9 US centers between December 2017 to June 2019, aiming to evaluate the efficacy and safety of the endoscopic sleeve gastroplasty with lifestyle modifications compared with lifestyle modifications alone. For the ESG group, during the procedure, the overstitch system by the Apollo Endosurgery Company was used. It involves placing 7 to 9 permanent full thickness sutures in a running U-shaped plication extending from the antrum to the OGJ with fundal sparing, and each set of the sutures consists of 3 to 4 superimposed sutures in a triangular pattern, leading to the collapse of the stomach pouch. In the control group, only lifestyle modifications were used, which is a standard moderate intensity lifestyle intervention adjusted to each participant's need, including low-calorie diet plan, physical activity involving 150 minutes of aerobic exercise per week, and each individual is encouraged and assessed for their compliance during the study. The study involves two phases. In the first phase, patients are randomized into the ESG group and control group, and it is being regularly followed up for 52 weeks. And at the 1 year time, the primary outcome of the percentage excess weight loss associated with other secondary outcomes are assessed. In the second phase of the study, it begins at the 1 year time when the ESG patients are allowed for selective retightening, and the control group is allowed, and the control group patients with inadequate weight reduction is allowed for crossover to have the ESG procedure, and they are followed up for another 52 weeks. For the results, they found that the primary outcome of the percentage excess weight loss at 52 weeks were 49.2% in the ESG group compared to only 3.2% in the control group, associated with improvements in the metabolic comorbidities and also a 68% of the patient in the ESG group maintained more than 25% of excess weight loss by 2 years. Hence, they concluded that ESG is a safe intervention with significant weight reduction and should be used as a synergistic weight loss intervention. So now let us look deeper into this study design and the methods, and I will critically appraise each step according to the consult guidelines. First of all, I think that this is an important clinical question as obesity is becoming a global concern. Although the evidence for bariatric surgery, including sleeve gastrectomy and root-wide bypass, is well established, these procedures are being limited by their invasiveness and irreversible nature. Recently, a less invasive approach by the ESG has been introduced, which has the advantage of being reversible, endoluminal, and also organ sparing. However, it lacks RCT to demonstrate the efficacy and also safety. Therefore, I believe that it is an important study question to compare LSG with lifestyle modification alone to know the efficacy and safety of this new procedure. And I believe that an RCT is an appropriate study design because a well-conducted RCT can provide high level of evidence, and also randomization can help to reduce confounders and bias compared to observational studies. Also, class 1 and 2 obesity is a rather common disease, making recruitment for an RCT not that difficult. For the study population recruitment, this study is a multi-center study involving 9 US centers. The advantage of having a multi-center study is that it allows larger sample size, higher generalizability, and also higher external validity. Yet the drawback is that the results interpretation will be more difficult due to the heterogeneous nature, as there are different patient characteristics, case volume, clinical practice, and surgical techniques across different centers. In order to increase this generalizability, this study specifically involves different specialties, including bariatric and gastroenterology centers, different practices in community, private, and academic centers, and also different levels of the previous experience across the across the performers. However, they didn't provide adequate information about the case volume of each center. So this is one of the drawbacks of the study. For the inclusion and exclusion criteria, there is actually a very long list listed in the appendix. Most of them are being reasonable and well-defined. However, for the inclusion criteria, I think that they added living nearby as one of the inclusion criteria, which may not be that clinically relevant. And also they controlled the quota for those without comorbidities to be less than 50, which may add selection bias. And for the exclusion criteria, they specifically exclude patients who are insulin dependent. And however, this may represent a significant portion of patients with obesity and metabolic syndrome. Hence, it again will lead to selection bias. For the sample size calculation, they assumed that 25% of excess weight loss in the ESG group, and also there will be a 10% of EWL in the control group, which was based on previous observational studies in a meta-analysis. And in order to detect this 15% of difference, they use the alpha to be 0.05 and power to be 80%, and also a dropout rate to be 45%, and estimated that a total of 200 patients is needed. And hence, in 1 to 1.5 ratio of randomization, 80 patients in the ESG group and 120 patients in the control group will be needed. However, it is worth to note that the dropout rates proposed by the authors are actually exceptionally high compared to our usual practice. Hence, we may argue that the authors try to overestimate the sample size and aim to produce a more significant result. And for the allocation concealment, the red cap is used for the randomization. Hence, it allows concealment to prevent prediction for the randomization results. So this is one of the good side of the study. And for the randomization, it is performed using a stratified permuted blocks. And using stratification can allow the even distribution of the confounders, including those with and without comorbidities. And using block randomization can allow the control of patient numbers in each group. However, the block size was not specifically mentioned in the study methods. And for the randomization, it is a 1 to 1.5 ratio, which is an unequal ratio. The good thing about this unequal ratio is probably to be more cost saving, as relatively less patients will be allocated in the ESG group. However, a larger sample size must be needed in order to maintain the statistical power of the study, having an unequal ratio for randomization. And for the blinding, only clinical staff involved with lifestyle management program were blinded. However, double blinding is not possible due to different treatment modalities, and sham endoscopy is not performed due to the associated risk. And therefore, the lack of blinding is one of the major disadvantages of this study, which creates performance bias and also observation bias. For the intervention, authors try to standardize the procedure across different centers by providing a technique video developed by the principal investigator. And the first two cases were being proctored by the independent expert. However, we must know that the learning curve is actually not taken into account in this study. And apart from the ESG procedure itself, the lifestyle modification in the ESG group is actually slightly different from the control group, which involves a 6 weeks transitional diet post ESG to allow the suture healing. And also at the second phase of the study, retightening was selectively offered to patients with suboptimal weight loss. And there may be selection bias because they didn't specify the criteria for choosing patients to have a retightening. And also, there is no routine endoscopic assessment for all the patients with ESG group. So there is lack of objective assessment for the durability of the stitches. And for the control group, at 52 weeks, a crossover is allowed in case they do not have adequate weight loss of more than 25% of EWL. And however, because of the lack of blinding, there may be performance bias in this control group of patients that will lead to difficulty in interpreting the result. And for the outcome measurement, I think that the percentage excess weight loss is an objective and commonly used measurement for weight reduction after bariatric procedure. So it is well chosen. And also it can be just simply measured by a standardized formula. However, the follow-up period is only 52 weeks, so it is too short to detect the sustainability and durability of the procedure. Otherwise, the secondary outcomes are appropriately chosen. And for the follow-up, it was specifically mentioned by the authors that the COVID-19 pandemics actually limit their follow-up because sometimes they cannot follow up the patient in person, and also difficult to monitor their clinical parameters and laboratory data. And for the statistical analysis, they were analyzed in per protocol analysis and also modified intention to treat analysis. At the modified intention to treat analysis, those who did not receive the intervention or who meet the exclusion criteria even after randomization were being excluded for the analysis. And therefore, both methods for analysis create attrition bias. And for the missing data, they were simply treated as ignorable missingness. And but the good side is that the sensitivity analysis is being performed using last observation carried forward for the missing data. So I think it is quite appropriate. And lastly, and most importantly, it is important to note that Apollo Endosurgery Company actually is one of the funder of this study, and therefore there is possible agenda-driven bias or performance and detection bias in the study. So next is the results. This is the consort diagram for the result, and we can see that a total of 209 patients are being randomized into the ESG and also control group, yet only 77 patients in the ESG group and 110 patients in the control group were being treated, as some of the patients were found ineligible after randomization. And therefore, when we use the modified intention to treat analysis, we can see that only 77 and also 110 patients in the control group were being analyzed, which is already less than the proposed sample size according to the sample size calculation. And for the baseline characteristics, they are more or less similar, yet it is worth to note that the control group is actually having a relatively higher proportion of patients having comorbidities, especially for DM, although it was not mentioned about whether this baseline imbalances are statistically significant. And these are the graphs showing the weight reduction comparison across the two groups. We can see that for the primary outcome, there is statistical significantly higher percentage of excess weight loss in the ESG group. And however, if we look deeper into their appendix, we can see that there are site-specific results which is heterogeneous across the case distribution. Some centers actually have only single digits of number of ESG performed. And also we can see that there's a wide range of 95% confidence interval across the in some of the centers. So there could be some bias in the performance across centers. And I believe that this bias can be actually prevented by stratifying according to the institution during the randomization, and also more standardized training and ensure an adequate learning curve is needed prior to the implementation of the study. And the comorbidities were also being assessed, and although they reported a statistical significant improvement in diabetes, hypertension, and also metabolic syndrome, I believe that the follow-up period is too short for these results to be to show sustainable benefit. And otherwise, for the adverse events, only 3 patients have complications such as abdominal abscess, and GI bleeding or malnutrition, which are well managed. There's no mortality associated. And so this study in the end concluded that ESG induced clinically meaningful weight loss and comorbidities improvement. However, from the previously mentioned points, we know that the follow-up period is actually too short and the sample size is not enough to demonstrate any sustainable weight loss and long-term changes in the comorbidities. And to conclude, will this paper change my clinical practice? First of all, I still agree that this is a worth exploring topic and clinical question. And however, the results of this study should be interpreted with caution due to the potential bias. And also because of the ethnic difference, there are only 0 Asian patients undergoing ESG in this study, so it may limit the generalizability to my own population. So in future focus, I believe that we can look more into comparison of different endoscopic methods, such as intragastric balloon versus ESG, or some pharmacological methods, such as the new GLP-1 agonist versus ESG. Thank you very much.
Thank you, Carol. A very comprehensive overview of the paper, and I'd like to invite, perhaps ask Ravi or Anthony, would you like to discuss this paper first, or ask Ravi to do it?
Okay, sure. I can ask some questions. Yeah, Dr. Lai, very comprehensive review. So just simple question. So you mentioned there are a lot of issues in terms of the study design. So if you were to do this study, how would you improve the design?
Thank you very much for your question. First of all, I think I would still perform a randomized control trial, and also a multi-center approach would be good to involve a larger sample size. And however, during the procedure itself, I would use more standardization of the procedure, including giving more tutorials or more proctorship for the to ensure a adequate learning curve for each endoscopist. And also I would have a longer follow-up, including which may last for at least 2 to 3 years, to look at the long-term sustainability of each patients. And also for the ESG, I would also perform a routine OGD to assess for the suture patency, because from our center's own experience, we can see that some of the patients with history of endoscopic sleeve gastroplasty, their stitches actually loosen within 1 to 2 years. So maybe a more routine OGD can use to have a more objective assessment for the durability.
Yeah, so I would like to add, because I think ultimately the hypothesis is to prove that the ESG works in terms of producing weight loss. So I think with this in mind, we need to control better the control group. So meaning in the control group, as we know, all these patients will have a strong psychological component. So if we do not do a sham procedure, meaning do a OGD and pretend that ESG has been done, they have a strong psychological component, knowing that they haven't done anything and they are not willing to undergo the weight loss. So the control group may not be performing as well as we would assume, and it was reflected by the data. And of course, during COVID, all these patients are stuck at home. So they couldn't have come back for follow-up, and they couldn't see the dietitian, or they couldn't see the physiotherapist or go to the gym to work out. So, but then I think, as you mentioned in this study, the control group was not performing as well as we would imagine. And then the lack of a sham intervention also adds to the psychological component. Because we are just wanting to prove that the ESG works. So actually all the reinterventions after 1 year, as you mentioned, is a little bit complicated. So in the ESG group, all the patients were assessed if retightening was required. As far as I know, I don't think this is kind of like a standard therapy. So this is more like a physician initiated kind of intervention. So it's it's a bit non-objective, very subjective, and subjected to the patient's symptoms, and also subjected to the endoscopist assessment during the OGD. So this actually adds to the heterogeneity. And also in the intervention group, I'm a little bit surprised that they were allowed to cross over after 1 year. This adds to the complexity of the study. I think maybe the reason behind this is that all these patients were asked to join the trial, and they were allowed to receive the procedure without too much cost. So maybe this was added in the later part of the study so that there would be more initiative for them to join the trial. So knowing that they haven't been randomized initially, but after 1 year, they may still have the chance to electively receive the procedure, maybe kind of like an initiative for them to join the trial. But in terms of the study design, I think that this adds a lot of complexity to the study. And I agree that the dropout rate was really high, so like almost 50%. So that amount of patient lost to the study could have changed the study results significantly. But of course, I personally, I think ESG works. But in Hong Kong, we haven't introduced ESG as much as we would want to. One of the things that for me would be a concern is that in Hong Kong, we still see a proportion of patients with suffering from gastric cancers. So after gastroplasty, it will definitely affect the stomach surveillance. And I don't know, it's just always in the back of my mind, so if we sew up the stomach, maybe there could be some tumor developing in that area that we cannot survey. Of course, the patient population is not really in that population, but in the back of my mind, this is something that could happen. So this may affect the popularity in the Eastern or Northeastern Asian population. So that's all I want to say. Ravi, do you have anything you want to add?
Maybe I will share a different perspective of this study, having been doing bariatric procedures. I'll try to share some slides on it. Okay, can you see the slides?
Yes.
Thank you, Carol, for a briefing about the trial. As we know, endoscopic procedures are completely different from surgical procedures. Although we try to aim to replicate what surgery does in terms of restriction, but the endoscopic procedure has its own benefits and limitations. The limitation here, as we can see, this is not meant to be as restrictive as a surgical procedure. But the benefit here is this is reversible, it's organ sparing, there is no change to vascular blood supply or anatomy of the stomach. Surgery has been conventionally used for patients more than BMI 40 or patients BMI more than 30 with comorbidities, with recent guidelines trying to even come lower, use a lower BMI for surgery. And endoscopy has been advocated for patients BMI more than 30 or those who are in the overweight range. In Asians, it even comes down to 27.5. The problem is, having said the surgery has been around for the last 50 years. The technique has expanded, modified, there are like new versions of bariatric surgical procedures, but the problem is it has only penetrated to the lonely 1% of bariatric population, leaving behind a huge group that is still left untreated. And the hope what endoscopic procedure is trying to achieve is whether we can address this untreated group of population. Let's say in Singapore alone, the obesity rates are around 11% now, and it's expected to rise. And on average, we do around 400 to 500 bariatric surgeries in the whole country, which leaves behind a lot of patients who are really untreated and significantly add to the healthcare burden in Singapore. And I'm sure it's the same in the rest of Southeast Asia. So 4 different devices. The main player is endoscopic sleeve gastroplasty, which has an FDA approval. Then is post-procedure, and then endobina and endosip. Endosip is an experimental device. Post has a CE mark and an FDA 510K approval for tissue apposition, and the same applies for endobina. So ESG is the only device which has an FDA approval for obesity indication. Is MERIT trial the first randomized study on any endoscopic procedures? I would say no. The first randomized study was POSE, which used the randomized sham control trial to assess whether the POSE procedure was effective in treating patients with obesity. Same like how ESG was designed, but they did not manage to meet the primary endpoint because the way the trial was designed, the way the training was conducted, and the way the follow-up was spanned out. So ESG trial tried to overcome some of these things that we learned in the process when we conducted earlier sham control trials. So what do we do in an ESG procedure? Is basically we do transmural sutures with an intent to narrow the stomach. These are continuous sutures starting from anterior wall, mainly involving the greater curvature of the stomach. Then we go to the posterior wall, and again in a U-shaped pattern, you go back where you started, so that with an intent trying to bring the anterior and posterior wall of the stomach together to create a restrictive lumen. And then we don't involve the fundus of the stomach so that these patients don't get any reflux disease, which is increasingly becoming a problem when it comes to sleeve gastrectomy. So this was the suture pattern which was adopted in this study, and on top of it, they had reinforcement sutures. And typically after procedure, the way the stomach looks is you can see that the greater curvature of the stomach is completely collapsed. The fundus of the stomach is spared. You restrict the lumen significantly. So the question is, what did MERIT trial do to endoscopic sleeve gastroplasty as an obesity treatment? Prior to this trial, there was at least 40 to 45 clinical studies, mainly from expert centers and some community centers, both prospective and retrospective. Some are like case control studies, establishing it as a weight loss, effective weight loss treatment. But there was no level 1 or level 2 evidence, unlike bariatric surgery, which has been around for a long period of time. So the one thing which MERIT trial tells us is it has given a level 2 evidence saying that it is safe, it is effective to see improvement in comorbidities, but just that we don't have a sham treatment. But it also has proven that ESG by itself is not a sham treatment. It is effective in inducing weight loss. And in terms of patient population, these are the patients we do see in clinical practice. The trial was, they didn't specifically choose patients who are just obese without comorbidities. They wanted to show that it also induces weight loss, it also improves improvement in comorbidities. So they were, in a way, good in terms of including patients with obesity and comorbidities. In practice, we may see patients both with obesity who are metabolically healthy and those who are metabolically unhealthy. So they kind of brought in both group of patients for the study. The technique in the last 5 years, it's almost standard. Most centers follow U-shaped pattern. Almost all of the procedures involved in this study were brief. The technique was standardized. The PI was at each site to observe how they are doing. Although there were inter-center differences in terms of weight loss and number of cases, but we look at overall, the weight loss is somewhat similar and there's no statistically significant difference, except for 1 or 2 centers which had a lower response rate. Compared to the initial post-trial, here we used moderate intensity lifestyle intervention compared to post, where they used low intensity lifestyle intervention. So this is something which most patients can follow, akin to what we recommend for patients who come for diet and lifestyle intervention alone. And the study in a way was very tightly ring-fenced, so the safety was their priority, and they showed that they want to stop the study if there is even one death or any serious significant adverse events. Compared to other randomized study, one thing which was quoted was the dropout rate was high. In fact, based on prior publications, I think the reason why the authors factored in a higher dropout rate in their power calculation is because of prior studies showing both prospective and retrospective showing increased dropout rates. But what we see in a well-designed randomized control trial is their dropout rate was as low as 16%. It's not very high. And in terms of follow-ups, one of the critical change that was done compared to previous randomized trial is all these patients had to come for follow-ups. Without follow-up, it is impossible to change patients' behavior. It is impossible to change patients or follow up on patients' dietary habits and so on. So they made it a point that patient has to stick to at least these 12 clinical visits during the first year after ESG. And the same applies for patients who had a diet and lifestyle intervention. In terms of crossover, they also made it a point that not all patients can be crossed over to ESG. You need to have at least 2/3 of these clinical visits fulfilled before you can cross over to ESG in the diet and lifestyle group. So they kind of selected those patients who are compliant in order for us to actually see results. To a certain extent, follow-up is very important in bariatric endoscopy or any obesity management. If we see patient once and if the patient comes back at 6 months after procedure, we are not going to see good weight loss results. And it is hard for us to intervene or establish compliance in this group of patients. So as stated based on ASMBS, which is guidelines, the excess weight loss is more than 25% in almost 77% of patients. And the percentage total body weight loss is 13.6, which is relatively higher, and more than 62% of patients achieve more than 10% weight loss. In obesity management, the goal in any obesity management is to achieve at least more than 10% weight loss for us to see improvement in most obesity-related comorbidities. And if we look at it, where we shall place ESG based on the results from MERIT trial, given all the different treatment options available for obesity, I think ESG is well ahead of current widely approved pharmacotherapy and moderate and high intensity diet and lifestyle measures. But as expected, it's not going to be more than surgery. It's trying to bridge the gap between pharmacotherapy and surgery, which is essentially the biggest population that we see. And with this weight loss, as expected, we can see improvement in diabetes, hypertension, and all metabolic comorbidities. And none of these patients had reflux. Yes, agreed, this study is, the objective of this study is not long-term, but at least at short-term within the first 2 years, as the study showed. We can see that these comorbidities would be maintained as 68% of the patients continue to maintain their excess weight loss at 2 years. And again, the primary safety endpoint, there was no serious side effects in this group of patients, and it's pretty safe. The question about retightening is retightening was primarily performed in those who are non-responders and at the discretion of procedurists in selective responders. Retightening has been done in prior studies too in a select group of patients. The only thing which we need to understand based on our own experience and published literature out there is it doesn't work that well in those who has not responded primarily. If somebody who has ESG and if they have not responded well to ESG, retightening them is not going to make them induce more weight loss. We may need to look for alternative options. We may need to even look for reason why these patients did not respond at the first place. Retightening works only in those who have responded following the primary ESG. So this, even in clinical practice, it's the same. Somebody who has lost a lot of weight, for some reasons they regain weight, and when we subject them to repeat ESG, they continue to lose weight compared to those who have not responded from the word go. So can these results apply to my practice? I would say yes, because the study involves both experts and community centers, surgeons and gastroenterologists are involved. There is a mix of patients, and diet and lifestyle intervention is very similar to what we recommend in real world practice. And more than that, the population of obese who we are dealing with is a lot. And this group of patients certainly need some help, and not all would be wanting to go through surgery or pharmacological treatments. So if ESG is safe in short term, it certainly can induce weight loss for them to actually take the first step towards achieving their goals. In this study, there were less Asians. They excluded insulin-dependent diabetes and patients on pills. But from our own experience in Singapore, treating Asians on insulin-dependent diabetes, even those patients who have failed pharmacotherapy, our one-year weight loss results was around 20%, with a follow-up loss rate of around 24%. So, in fact, it works even in Asians. We tend to do these procedures for even a lower BMI, starting at BMI more than 27.5 in Asians, because we know that the risk of metabolic comorbidities tend to be higher in Asians at a lower BMI compared to Western population. So yes, the results are good. It is safe. It induces weight loss that is adequate to see improvement in comorbidities in short term. So we would consider, we have been offering ESG as a treatment to patients with obesity. And so far, the results that we observe in practice is akin to what the randomized study has shown. So in conclusion, I would say ESG is safe. The study has proven, and all other available studies that are around, including meta-analysis involving over 6,000 patients from prospective and retrospective, have all shown that ESG is safe and effective. And then I think we should consider treating these group of patients and offering them ESG rather than subjecting patients to continued lifestyle intervention, when we know that not a big proportion of patients would achieve significant weight loss with lifestyle intervention alone. Moving forward, what would be the next step for ESG? This is the first step forward, and I think at short term, we have shown it works. In medium term and long term, we are yet to observe. But in my personal opinion, I think in long term, we are going to see weight regain as a big problem after ESG. But at medium term, the couple of papers out there from prospective cohort study shows that the weight loss results appear to be maintained reasonably, but that yet needs to be seen in a large group of studies, and we need to see whether that's replicable. I'm not saying now the pharmacotherapies are even amazing. There are good drugs coming out with better weight loss results. We need to see how ESG compares to these results, but patients sometimes may not be liking injectables for a longer duration of time, and these injectables induce weight loss only at higher dose, and they also have a lot of symptoms and side effects. The time we stop, weight regain is still a problem with these drugs. However, compared to the past, the pharmacotherapy now is much better. The evolving RCTs combining, let's say, semaglutide and ESG have shown even superior weight loss results, as close to 26% that was published in DDW a year or a couple of years ago, which is impressive. So what we need to know is we need to have more such trials to see how ESG compares to novel pharmacotherapy, or even in combination how they do and compared to surgery. So if given an option, patient may avoid invasive procedures. And of course, cost-effective studies and key outcomes like cardiovascular and mortality benefit needs to be shown. But for now, based on the evidence that we have, I think ESG should be offered as a treatment for obesity, at least for us to see short-term benefits. That's my take.
Thank you, Ravi, offering a very different perspective. I think we have about a quarter an hour to go, and why don't we open questions to the floor and we invite questions from the participants. Just a question for Ravi. ESG is really for the less obese patients, and in this particular study, BMI less than 40, correct? So you are actually extending your indication to someone who are, you just mentioned that even in the 27, 28, you still offer ESG?
So in Singapore, since majority here are Asians, and based on the prior WHO statement that the risk of comorbidities tend to occur higher in Asians, so we have lowered our threshold to offer ESG for patients with a BMI more than 27.5. If you look at the current surgical guidelines on indication for bariatric surgery, they're also trying to lower the BMI scores so that we can penetrate the treatment to a greater population so they can see benefits. And interestingly, I think a few days ago, we even had a recommendation from American Association of Pediatrics on weight management for kids. They have even started recommending use of pharmacotherapy or bariatric surgery even for kids at a very young age. So I think what we are seeing is a huge increase in obese populations, and the existing treatment that we have has not penetrated well. So we really need effective options, and that can help patients to achieve their goals. So 27.5 is okay.
Do you really think it is as safe as it claims to be? Speaking from my own personal opinion, I've seen a case of mesenteric venous thrombosis because of transmural suturing, and in that particular case, the patient had gut ischemia. So, so less than 5%, and not in the MERIT trial, but in the other trial, there was a mortality. So it's a bit of a price to pay just to lose a few pounds. And do you really think that it's just as safe as what it proposes to be?
So from personal experience, in our program in Singapore, we have performed more than 100 patients so far. We have had none of such complications that has been reported. The only thing which we had, there was only one event which we had out of these 100 patients where the patient had GI bleeding immediately after procedure. That was treated with endoscopy. So we have not had any other serious adverse events so far. I think certainly there is a learning curve to this procedure. So I think if you're comfortable doing it, if you're familiar with the technique, I think the risk of complications can be avoided.
Chris has a question.
First of all, thanks, Dr. Caroline, for that excellent presentation and critical appraisal on point by point, and I quite appreciate it. And thanks for Anthony and Ravi for their perspectives on that. So for me, looking at the population that was treated in this trial is predominantly a Caucasian population. And also in the West, there's a higher incidence of morbid obesity compared to Asian countries. So my take here would be ESG would be more perfectly suited to the Asian population, where you are seeing metabolic syndromes at a lower BMI, and a more minimally invasive way of managing them with endoscopic treatment. That's one of my comments here, and I would like to take what the others think about it. The second thing is obviously the cost effectiveness also comes into play whenever you are having any interventions as such in healthcare. it is important to see what the non-intervention, for example, pharmacological interventions, the cost of doing it along with lifestyle compared to this will also be helpful. In another way, is the juice worth the squeeze? And that's something which I would like to consider here, and I would like to take your views. Thanks.
Okay. Other comments from panel members? And the other critique of the merit trial was that there were many centers, but then there were many centers which enroll 1 or 2 patients. So, and over an extended period of time, presumably 1 to 2 years. And that in itself, I interpreted this as a kind of a bias because you actually select some of your patients. Would you agree with that, Ravi and Anthony?
I do agree. I do agree with that. There are a few centers, I believe, probably there are like community centers, maybe, or private practice where the uptake is less compared to academic centers, which in fact enroll more. I probably believe that there is a certain amount of bias in terms of recruitment because of that. However, if you look at centers that has been recruiting more, the weight loss kind of like mirrors. So it's okay. But so your point is you're right in a way, saying that the distribution of cases is not similar across different centers.
Right. Okay. To comment, Carol, you've alluded to the fact that some of the centers enroll single-digit number of patients, and that would limit its generalizability. But then Ravi argued that because of the fact that not only academic centers enroll patients and also community centers enroll patients, that improve the generalizability. So a bit of a conflicting opinion here. What is your view, Carol?
Maybe I just answer this as well. I think, of course, ideally you want all centers to be contributing equal numbers of patients, but in practice, I mean, we often done randomized trial. You know, some centers may not start at the same time. Some centers may start only after 2 years, and then by the time they start recruiting, they only recruited 1 patient. So I think there's many factors. I mean, of course, it might be some bias, but I think sometimes it's just practicality.
I think it's more related to practicality, like what you mentioned, which is what I think could be the reason why there is uneven recruitment between different centers, rather than, I mean, let's take it that way. It's practicality more than preference.
And the other question is what is the learning curve? I mean, how many cases do you need to do and before you declare yourself competent? And obviously, it's the complication is going to be an ongoing process, auditing your own complications. So how do you learn, and how do you declare yourself competent?
In terms of learning curve analysis, to guide us, there are not many literature out there except for a couple of them. One coming from Well Corner. What we would want to achieve when we do these procedures is we want to achieve mastery rather than just learning how to do a couple of sutures or something. So in any endoscopic procedures, we always want to achieve mastery. Based on the available evidence that we have, it says that at about 50 procedures, you reach mastery. At about 30 procedures and above, you become comfortable doing endoscopic sleeve. From personal practice, I think that somewhat reflects in terms of achieving mastery. I think when I started, I was proctored, I was monitored, then you audit how you perform, then you look at your time, you look at your complication rates. I think it's around 40 to 50 procedures where you kind of like become you achieve mastery, I would say. You know what's happening, what you're doing, and what's going wrong.
Okay, but in a few years, do you prefer all patients coming to Singapore General Hospital, or you prefer patients, some of them would go to a community center to be treated?
In Singapore,
you see what I mean? You say I think that there has to be a critical volume before you can maintain standards, so to speak.
I think the volume is there. If you ask me, the volume is there. As I can speak for Singapore, like in here, we were the first center to start, and now there are other centers which are starting. Singapore is small, but yeah, I'm sure this applies to Hong Kong too. In terms of the volume is there. The important thing is expertise.
Okay. Anthony, can you update us as to what is happening in Hong Kong? Endoscopic sleeve gastroplasty. We've done a few, I think, but we've not done as many as.
Yeah, I think we've done a few, but it hasn't gained as much popularity as that in the West. Again, for reasons that I've mentioned, so we still have a sizable gastric cancer proportion population. By doing ESG, we're excluding part of the stomach from surveillance, so it's a bit of sometimes on the back of my mind. It might cause future problems. I think in Hong Kong, the major procedure is still sleeve gastrectomies, and we are doing very few bypasses. In terms of
certainly we have the volume to grow. Am I correct? We are not doing as many as we should.
Yeah.
Okay. I think in the interest of time, I think we need to close. There are a few people that I like to thank. I think Chris needs to be thanked because he is the person who initiated this. And we were also in a research forum together. When he was the WEO Research Committee chairperson, we actually initiated some training sessions. So this is the first of its kind. So we are hoping that members from WEO and also the Asian Endoscopy Research Forum would be able to contribute. We've had a good session. I thank Carol for summarizing the study and also critically critique the study, and also thank Anthony and Ravi for their comments, and particularly Ravi for an alternate view, and then share with us what is going on within Singapore, and also provided an overview of what things will come in the future. So with this, I'd like to end the session. I hope that you agree with me that it has been a good session, and we'll be continuing this, and hopefully in a month's time, and we'll select another journal article and ask a junior faculty to comment and a few discussion to comment on the papers as well. So thank you guys. Thank you, Chris, Ravi, Carol, and Anthony. Professor Tajiri perhaps has left, but anyway, thank you again. I'd like to end this session, and thank you very much.
Thank you. Thanks, James. Thank you very much.
Thank you.
Thank you.
Thank you. Thank you all. Thanks for having me.
Thank you.
Thank you.